we'll be talking a little bit about anticoagulation and antiphospholipid syndrome. And just to kind of start off, I have a couple objectives that we will cover during this presentation. One of which being the understanding the limitations and evidence for primary and secondary thrombosis prevention in antiphospholipid syndrome. And the second being understanding the efficacy and differences between varying agents in management and prevention of thrombosis. So before we get started and dive deep into this, there's a lot of terminology, a lot of letters that are encompassed with this. So I want to make sure we just kind of highlight a few things. So we will cover a little bit more of it as I continue on, but when we talk about terminology and when we think of antiphospholipid syndrome, abbreviated as APS, there's a couple different types. So one being thrombotic APS. So this is basically describing patients diagnosed with APS based on venous or arterial thrombosis and persistent laboratory criteria for antibodies for antiphospholipid syndrome. The next one is obstetric APS. So this describes patients diagnosed with APS based on a couple different pregnancy defining morbidities, so including fetal death after 10 weeks of gestation, premature births due to severe eclampsia or placental insufficiency, or multiple embryonic losses and persistent laboratory criteria. So the last one here is CAPS, or catastrophic APS, and this is a rare, life-threatening form of APS characterized by thrombotic complications, including both macrovascular and microvascular. So it affects multiple organs that develop simultaneously over a short period of time. As we look at additional terminology, so antiphospholipid antibodies, abbreviated as APLs, they are laboratory findings of APS. So when persistent, that's over 12 weeks, these antibodies are a component of the clinical syndrome of APS. So they can also be seen as a transient finding following infection or other acute illnesses. But there are three that we look at specifically when we look at APS. One of them being anticardiolipin, anti-beta 2 glycoprotein 1, and then lupus anticoagulants. So these will be abbreviated throughout the presentation as ACL, anti-beta 2 GPI, and LA. So we talk a little bit about an overview of antiphospholipid syndrome. It is a systemic autoimmune disease. It's kind of defined by a spectrum and characterized as a spectrum, but when we look at it, there's a couple characterizations that we look at, which is venous or arterial thrombosis, and or pregnancy morbidity in the presence of antiphospholipid antibodies that persist over time. So as you can see from on the image to the left, there's a couple different things that we encompass, which are those antibodies that we just talked about. We talk about the thrombosis as well as, and this is an and or pregnancy-related morbidity. So APS can occur as a primary condition, or it can occur in the presence of systemic lupus erythematosus, or SLE. So this can happen specifically with SLE, can be completely without it, or it can be another systemic autoimmune disease. APS can be further classified according to the type of clinical manifestation, so thrombotic or obstetric. In some cases, both may be present, and then in catastrophic APS, life-threatening multi-organ involvement is present, and that can occur in either one of those cases. When we look at prognosis in APS, it really is dependent upon the clinical manifestations that led to the diagnosis. During a 10-year observational study that we looked at, the causes of morbidity and mortality of over 1,000 APS patients, the following was seen. So below you'll see a lot of words, but basically highlighting that recurrent thrombotic or thromboembolic events occurred in 120 to 166 of patients. Half of them were taking warfarin. APS-related manifestations included thrombocytopenia. They included seizures, heart valve thickening, or dysfunction, and they even looked at hemolytic anemia for a lot of the patients. Other things like skin ulcers were also apparent in this population. Over the 1,000 patients, 127 became pregnant. There was 188 pregnancies in total, with about 73% resulting in one or more live births. The most common complication was early pregnancy loss at about 17%. Then we looked at premature births and growth restrictions as well. Mortality in this group was about 9.3% over the 10 years. So it gives us a little bit of an idea of what it looks like to be diagnosed with it. when we look at primary thrombosis prevention, we look at what that therapy used in individuals with obstructive APS or isolated APS with their antibodies have, as well as, primary prevention refers to antithrombotic therapy used in individuals with obstructive APS or isolated antibodies who have not had APS-related thrombosis. So the question of primary thrombosis prevention is raised when a patient is found to have positive antibodies on testing that have been done for reasons other than as a part of an acute thrombosis workup. So a couple examples in which the presence of APL may be identified for reasons other than thrombosis include the evaluation of lupus, recurrent pregnancy loss, skin lesions of the legs or feet, unexplained prolonged APTT, unexplained thrombocytopenia, or a positive syphilis test. So when we look at a risk of the first thrombus or thrombosis with an APL, the presence of those antibodies alone appear to be associated with a small increased risk of thrombosis in some individuals. So the data on which populations are at increased risk and the magnitude of the risk are limited and have been based mostly off of observational studies. So the following appear to be risk factors for a first thrombosis in individuals with APL. It's systemic rheumatic disease, or particularly lupus in this case, a high risk APL profile or triple positive APL. That is also can be persistent with high APL titers, but it doesn't have to be. When we think of a high risk APL profile, this is defined as persistent lupus anticoagulant, so LA. A double positive APL, so any combination of LA, anticardiolipin, or antibodies like anti-beta 2 glycoprotein 1. And then the triple positive APL is also a high risk profile, so having all three of those antibodies tested for and showing up. Additional risk factors for venous thromboembolism or arterial thromboembolism is another big risk factor here. So VTE, recent major surgeries, estrogen use, inherited thrombophilia. And then when we look at arterial, it's more of looking at hyperlipidemia and tobacco use, things like that. So continuing on, lupus is associated with an increase in these events independent of antibodies. So yet additional studies show a further increased risk in the presence of APL. So when we think about it, it's independent of those and it can be increased. You'll see those events be increased with lupus, but additional studies also show an additional increase when you add those antibodies. So a couple different studies here that I wanted to mention. There's a meta-analysis of about 2,000 patients with SLE that found patients that had one of those antibodies, LA, had 6-time increased risk of VTE, and patients with just any antibody, especially the ACL, had a 2-times increase of risk of VTE. As we looked at a 2014 cohort study, with over half of them having SLE, and specifically looking at patients with the antibodies, presence of a double or triple positives had a risk factor for future thrombotic events. So single positives was not an issue and was not found to have additional events associated. So when we continue to talk about primary thrombosis prevention, we think of what are the risks of thrombosis with those people with high risk APL profiles without any autoimmune disease. So in this situation, the results are very unclear. So do antiphospholipid antibodies contribute as a risk factor for thrombosis? Suggestions include that there are no increased risks during follow-up periods, and other demonstrate increased risks. So we have a little bit of both. When we look at a 2015 study that followed 179 patients without SLE who had an isolated positive LA for 3 years, amongst that group, only 7 of them had thromboembolic events. All 7 also had at least one additional major risk factor for thromboembolic. So when we talk about this, there are some limitations that we've kind of talked briefly about, but patients with antibodies but have not had a thrombosis or have APS defining pregnancy morbidity, we suggest not routinely using antithrombotic therapy. So that includes aspirin or anticoagulation of any sort. for primary thrombosis prevention. This suggestion applies to individuals with lupus and individuals with APS based on the obstetric criteria alone. Some may still choose to take aspirin for prevention if they would derive other benefits like colorectal cancer risk reduction, but this approach is used in patients with low baseline risk due to low quality evidence here that either anticoagulation or aspirin reduces the risk, and then we also have to consider the fact that it may increase the possibility of bleeding. So additional limitations here, the approach of not using aspirin or anticoagulation differs from the European Alliance of Associations for Rheumatology. They suggest that low-dose aspirin as prophylaxis in patients with high-risk APL profiles should have that, as well as they also state that low-dose aspirin can be considered for patients with low-risk APL profiles as well. So I included a little table or a little diagram here that highlights what the thoughts are when we look at the European Alliance and their guidelines. So I'm going to jump into some of the benefits of aspirin, especially when we look at the primary thrombosis and why certain institutions and certain organizations choose to use it. So a 2018 Cochrane review, about 9 randomized trials, included positive APL patients without a thrombotic event, concluded that there was insufficient evidence to demonstrate harm or benefit of aspirin or aspirin plus an additional anticoagulant. All trials here were at high or unclear risk of bias, which again lead to the decision making as to why this is unclear data. We also had the APLA-SA trial, so only randomized trial to compare aspirin versus placebo in individuals with persistent positive antibodies, but no history of thrombosis or pregnancy morbidity. This was about 98 patients, and 2/3 of them were positive for lupus and were randomly assigned. In that situation, there was no significant data that came about the trial and no real findings that could be implemented elsewhere. Looking at a 2014 meta-analysis, this subgroup analysis is basically where a lot of the data came. So there's multiple subgroup analyses that demonstrated that aspirin was protective against arterial, but not venous thrombosis. So that was one component of it. An additional analysis found that aspirin was only associated with statistically significant in reduction of thrombosis in retrospective, but not prospective studies. And then it also, in another analysis, limited to just females with lupus with a history of obstructive APS, found low-dose aspirin was associated with lower rates of thrombosis. Then the last study here, a 2015 meta-analysis, was strictly observational studies with positive antibodies found reduced risk of thromboembolism, and specifically in the arterial thrombosis in those treated with low-dose aspirin. So kind of highlights what we've seen in the other studies as well. When we look at management of thrombosis, there's some baseline testing that we look for. Testing for antiphospholipid antibodies with an additional testing at least 12 weeks after the initial test. Initial choices for anticoagulants based off clinical suspicion of APS with new venous or arterial thrombotic events. And then we think about when we need to suspect. So if a patient has one or more unexplained venous or arterial thrombotic events, especially if they're younger, one or more specific adverse outcomes related to pregnancy, including embryonic losses, less than 10 weeks gestation, fetal death after 10 weeks, or premature birth due to severe preeclampsia. We also look at patients who manifest valvular heart disease and or have neurological findings such as cognitive deficits and white matter lesions, which also then have suspicion for APS, and those are increased. So SLE also increases the suspicion for APS. So in addition to all of this, specifically having that, having lupus is another big increase in suspicion as to why we should test. Some additional tests here, we look at CBCs, baseline APTTs, as well as serum creatinine. A serum creatinine in urinalysis with urine sediment may help to identify kidney involvement in APS, and then abnormal findings may also suggest a concomitant or alternative diagnosis like lupus. Patients with abnormal kidney function, microscopic hematuria or proteinuria, or an active urinary sediment will need further evaluation. Additional testing when we look at just the antibodies. So there's a couple components here that we need to look at. So to have a positive APL test, you have to have 2 immunoassays and a functional coagulation assay in suspected APS. So we think of the ACL antibody as well as the anti-beta 2 GPI protein and the antibodies that are associated with that. Both of those can be quickly identified through an ELISA test. And then the last step is a 3-step lupus anticoagulant functional assay. So this encompasses 3 different parts. So prolonged test of hemostasis related to phospholipids, so that APTT, and then mixing of the patient's plasma with normal plasma, which may fail to correct the prolonged APTT. So that shows that an inhibitor is present. And then the addition of phospholipid shortens or corrects the APTT. So having all those 3 components can help us identify a positive LA, as well as the other 2 ensure that they have an actual completed positive APL testing. Now jumping into a little bit more of the secondary thrombosis prevention. So this is just a period of time after the initial 3 to 6 months of treatment for the acute thrombotic event. By this time, patients should have had a confirmatory antiphospholipid antibody testing to demonstrate the persistence of APL. When we look at long-term anticoagulation, the suggestions from the table to the left include anticoagulation with warfarin rather than DOACs, especially in cases with arterial thrombosis. So when we look at the data, the evidence behind those statements, so we look at evidence that show that DOACs are a little less effective than warfarin for recurrent thrombosis prevention in patients with APS. Yet the use of DOACs are appropriate in select cases of APS, such as those with lower risk disease, like a single venous thrombosis and low risk APL profile, or those who cannot tolerate warfarin or have been previously on a DOAC that we can find an additional use for. The low risk APL profile is defined as an isolated ACL or anti-beta 2 GPI at low to medium titer. So trials supporting the increased risk of recurrent thrombosis associated with use of DOACs compared to warfarin, a couple of them below. So we look at a specific trial that looked at warfarin compared to rivaroxaban over 3 years for secondary thrombosis prevention. In these patients with APS, and we noticed that rivaroxaban did not meet non-inferiority margins. There were additional recurrent thrombosis in the DOAC group, around 6.3% in the warfarin group versus 11.6% in the rivaroxaban group. Then recurrent thrombotic events in DOAC groups were mostly arterial, with recurrent stroke occurring in 10% of patients on DOACs versus 0% on warfarin. Again, trials supporting the increased risk of recurrent thrombosis associated with use of DOACs compared to warfarin. We have another one here, a 2022 open label trial comparing warfarin to apixaban over 12 months in patients with thrombotic APS. Again, this is a smaller group, but patients were randomly assigned to either or, and we found stroke occurred in 6 of the 23 patients in the apixaban arm, and stroke occurred in 0 of the 25 patients in the warfarin arm. When we look at VTE, there's multiple suggestions that include anticoagulation with warfarin, especially looking at a target range within 2 to 3 rather than a higher INR range within 3 to 4. Individuals who are pregnant or who become pregnant are treated with low molecular weight heparin in this situation, pulling them away from the use of warfarin. Suggested consistent with guidelines from the task force of the 13th International Congress on Antiphospholipid Antibodies. This also aligned with the American College of Chest Physicians evidence-based clinical practice guidelines as well. Again, looking at VTE, so the evidence here to support standard intensity warfarin rather than the higher INR range in patients with APS and VTE was supported by at least 2 of the randomized trials here. So the 2003 trial with about 114 patients with positive antibodies and a previous VTE or arterial thrombosis were assigned to receive either standard or high intensity warfarin INR ranges and regimens during a 3-year period. Trends during this time were toward thrombosis risk within the high intensity group were noticed. It was without statistical significance, but it was something of note. Within a different trial, we noticed trends more towards bleeding episodes in patients with the high intensity regimens, and that was about the only components within these two. Then looking at arterial thrombosis, so the optimal management of patients with APS here who have had an arterial event or an ischemic stroke or MI is a little less clear, and consensus among experts is really lacking. So options include standard intensity warfarin plus low dose aspirin, or the higher intensity warfarin. Again, individuals with prior arterial thrombosis have a higher risk of recurrent arterial thrombosis if treated with a DOAC rather than warfarin. For arterial thrombosis, there are suggestions to use more of the standard intensity warfarin plus a low dose aspirin. So again, these are from the guidelines of the 13th and 16th International Congress on Antiphospholipid antibodies. So they include these recommendations specifically for patients with APS to use either low dose aspirin plus standard intensity warfarin or warfarin at an INR goal of greater than 3. When we look at EULAR, it also includes the same options with an additional note to individual patient risks and to consider the bleeding with any of the higher INR goals. And then continuing on with arterial thrombosis, a couple of different studies here that looked at a couple of different components to use aspirin alone or to use aspirin plus warfarin. Both of them, it looks like there wasn't much of a consistent or a statistically significant component here, but they were found to have higher incidence of recurrent stroke in the aspirin alone group after 4 years, but it did not include a warfarin alone arm here, so it was a little difficult to do a full assessment. For a 2019 retrospective study of about 90 patients with APS and history of arterial thrombosis, looked at dual antiplatelet therapy versus other regimens, so a single antiplatelet agent, warfarin alone, or warfarin plus an antiplatelet agent. So it reported a lower rate of recurrent arterial or venous thrombosis with TAP. Due to the low number of individuals in each group, again, it did not meet a meaningful conclusion for practice in this study. So we continue to look at monitoring and challenges when it comes to secondary thrombosis prevention. For monitoring, for individuals with a normal baseline APTT who are treated with unfractionated heparin, the APTT can be used for monitoring. But for individuals with normal baseline PT or INR, warfarin can be managed by just standard INR and done in clinics for self-monitoring at home and self-management. The challenges lie where in patients that have elevated baseline INRs, and an alternative thromboplastin reagent may be utilized, which is very difficult as many institutions don't utilize this test, but it is shown to be sensitive to a patient's antibodies or specifically to the LA. Additionally, we can use an assay for factor 10 that uses a color change substrate rather than time to form a clot, and that could be used to help, but though this is not validated for warfarin monitoring at this time. If challenges with APTT monitoring to monitor therapeutic dose on fractionated heparin, we would utilize anti-factor 10A assays. When we look at duration, so how long are these patients going to be on anticoagulation? It is most likely going to be lifelong anticoagulation for patients with APS and an unprovoked thrombotic event. So this is based on likelihood of reoccurrence for the most part. Discussions in APS patients with provoked thrombosis with low titer APLs and can highlight risks and benefits to stop anticoagulations. But again, repeat testing should be repeated when those considerations are made. Evidence from retrospective studies show high rates of recurrent thromboembolism. However, there is also evidence suggesting that the actual risk of recurrent thrombosis in patients with APS who have received an initial course of anticoagulation might not be as high as previously thought. A review to assess the recurrence risk after a first VT found a trend towards an increased risk of recurrence after stopping anticoagulation. Again, that did not meet statistical significance. Additional agents to add here in secondary thrombosis prevention. We have a couple specific agents that have been used and routinely been used. Things like hydroxychloroquine, usually for add-on and difficult to treat APS, used routinely in lupus, but has insufficient data in use of APS or in positive APLs without lupus. It does reduce the incidence of thrombotic complications, which is a component as to why we are using it a little more off-label. Statins also add on for difficult to treat APS. They may have beneficial effect for patients by reducing pro-inflammatory and pro-thrombotic markers. We then have rituximab, which can be used in APL positive patients with hematologic manifestations or thrombotic microangiopathy. It does reduce antibody titers in several autoimmune diseases, and it shows its impact here as well. For reclusumab, this can be used in refractory APS and especially in CAPS or catastrophic APS that encompasses organ damage and additional organs. So when we look at recurrent thromboembolism despite anticoagulation, this is usually a rare and usually very oftenly unique patient specific as to why this would happen. We would ask, was the patient therapeutically anticoagulated with warfarin at the time of the event? If so, was there documented INRs? If within 2 to 3, without thrombosis risk factors, we could increase to a higher range. We could consider a switch from warfarin to low molecular weight heparin, especially in recurrent events when the INR was on the higher end at the time. And then considering additional agents, things like low-dose aspirin, hydroxychloroquine, and statin. Other treatment considerations, routine follow-up is a big component here, recommending to have APS patients be seen at least 1 to 2 times a year in outpatient settings. Lab monitoring of CBCs, metabolic panels to assess kidney function, and other labs pending organ system involvement. After confirmation of persistent antiphospholipid antibodies, repeat tests are not indicated. So after doing the initial test plus the additional test 12 weeks after, repeat testing is not indicated. We talk about risk factor reduction, minimization of modifiable risk factors for recurrent thrombosis. Those are always things we want to look at. Minimizing interruptions in anticoagulation, getting up and early to start ambulating, and then reducing venous stasis, as well as avoiding estrogen-containing medications. Additional considerations. Apologies for that. Looking at pregnancy for another treatment consideration, management during pregnancy is to be done with low molecular weight heparin instead of warfarin, as we had mentioned, especially in the first trimester due to risks of teratogenicity. So looking at other organ system specific manifestations here as well, cardiac disease, CNS manifestations, kidney disease, and thrombocytopenia, all of these have their own components that can cause some issues. So when we look at cardiac disease, there's cardiac valvulopathy due to non-bacterial thrombotic endocardial deposits, or NBTE, that can cause systemic embolic complications. For APS patients who have this valvular involvement, antiplatelet therapy and warfarin do not appear to cause regression of the valvular lesions, but these therapies may prevent clinical embolic events. Management of ischemic strokes in patients with thrombotic APS typically involves antithrombotic therapies and other interventions depending on whether the patient is already taking or receiving anticoagulation and whether or not white matter lesions appear on MRI. So in an individual with APL who has white matter lesions but no clinical suspicions of ischemic stroke, the role of low-dose aspirin is controversial. There is not a lot of data for or against the use there, but decisions on whether to use low-dose aspirin are generally made by evaluating overall cardiovascular risk. When we look at kidney disease, these complications of APS involving the kidney include APL nephropathy, thrombosis of arterial venous grafts in individuals receiving hemodialysis, and thrombosis following kidney transplant. And lastly, for thrombocytopenia, many individuals with APS have mild thrombocytopenia that doesn't really require therapy or treatment, but this thrombocytopenia could be a possibility due to a drug-induced or, for an example, HIP for a patient that's already on anticoagulation. So that is the conclusion of my real topic. I want to open it up to questions, anything that we could talk about as a group. Otherwise, I really appreciate you guys listening here when we go through a lot of specific studies and a lot of the data behind anticoagulation.